The broadcast is now starting. All attendees are in listen-only mode.
Good afternoon, and thank you for joining us for the second annual Healthy Transitions Colorado Educational Webinar. My name is Natalie Comp, and I'm with Colorado Healthcare Association. I'm very happy to be here with you today as we learn about and discuss how to reduce readmissions using a person-centered approach. CHCA is an operating partner in Healthy Transitions Colorado, the sponsoring campaign for this webinar. Healthy Transitions Colorado, or HTC, is a collaborative effort focused on aligning and accelerating existing efforts to improve transitions for care for Coloradans. Our guiding principles are simple. By working together to break down the silos of healthcare, we can foster true community care coordination across facilities, specialties, and practices. HTC coordinates the tools, resources, and efforts of many partners across the state. We want to keep Coloradans healthy so they can enjoy more of what our beautiful state has to offer. Our goals for this campaign follow the triple aim: eliminate 4,350 readmissions per year, eliminate over 34,000 days in the hospital over 2 years, and save $80 million for Coloradans over 2 years. If you haven't already done so, we invite you to become one of our community partners now and take the pledge to improve patient care transitions. To take the pledge and learn more about HTC, please visit our website at www.healthytransitionscolorado.org. I have just a couple of housekeeping items before we get started. The phone lines have been muted, but will be open for questions toward the end of the presentation. However, we also have the chat feature available to you to post questions at any time, or even if you just want to make a comment on the discussion. Questions posed to the presenter will be answered during the Q&A session after the presentation. To access the chat function, hover your mouse over the green bar at the top of your screen and click on the chat icon when it appears. Towards the end of the presentation, you will see an evaluation posted on the right-hand side of the screen. We appreciate your help in completing the evaluation and also encourage you to let us know what other care transitions topics you will be interested in learning more about. This webinar is being recorded and will be posted to the Colorado Healthcare Association website as well as the Healthy Transitions Colorado site, so you may access this information again at any time without cost. Our next webinar will be in mid-December and will cover the topic eye care, improving communications and readmissions in the rural setting. And now I want to turn the program over to Ms. Beth Ertz. Ms. Ertz is a registered nurse with over 30 years of experience in long-term care. She has held positions as Director of Nursing, Administrator, Vice President of Patient Care Services, and Chief Life Enhancement Officer. Beth has consulted in over 200 long-term care facilities in 20 states. Ms. Ertz graduated from the University of Kentucky with a BS in nursing, and she is currently an independent consultant and serves as the past board president for the Colorado Culture Change Coalition. Beth is also an Eden mentor and educator and is an adjunct professor at Arapahoe Community College.
Thank you, Natalie. Hello, everyone. I wish I could see your smiling faces, but we'll have to do without that today since we're doing this via webinar. I'm happy to be with you, and I appreciate the opportunity that Healthy Transitions and Colorado Healthcare Association has afforded me in giving this webinar. So I want to start with talking just briefly. I know many of you are probably very familiar with Eric Coleman's work. I became aware of his work in the last couple years and think it's really critical relative to creating healthy transitions for the people that are being rehospitalized. So just a quote I had on the first slide: hospitalization is disrupting to the elderly and puts them at greater risk for complications and infections. Hospitalization also increases the likelihood of reduced functioning on return to the skilled nursing facility. And based on my experience, we certainly saw that was true. In my most recent experience has been operating a skilled nursing facility where we took care of about 100, between 95 and 100 people needing skilled services or rehabilitation on a daily basis. And during that experience, we were able, using some of Eric Coleman's work and developing some things that we did internally in our organization, we're able to reduce our rehospitalization rate by about 10%, so from about 18% to about 8%. So I think those are relevant statistics. I think the state of Colorado has been hovering around somewhere between 8 and 10% over the course of the last couple quarters relative to rehospitalizations. Certainly that's an average, and your organization may have larger numbers than that. I know that the audience today is from multiple areas where the healthcare might be provided on the continuum, so I'll try to make sure that I'm addressing those forward as we go forward. I have focused a lot of the presentation based on my own experience and background in reducing rehospitalization rates. I do want to, before I really get going here, I do want to let you all know that I did log into the Healthy Transitions website. I did become a partner, and it's really easy. So based on what Natalie's already discussed with you, I want to encourage you, if you haven't done that and your organization is interested, go to the website, because it's really easy to add yourself as a partner, and there's a lot of partners there that I think some of us could learn a lot more about that I wasn't aware of when I looked at the website. So it's just food for thought for all of you. On one of the first, I think it's the third slide, I did pull some definitions about reducing hospitalizations, culture change, and person-centered care, since that's what the webinar is about today. So the reducing hospitalization definitions that I've posted here are right off the CMS website, and really talk about improving care and lowering costs. And the initiative that's going on at CMS in reducing avoidable inpatient hospitalizations within 30 days. The initiative supports the Partnership for Patients goal of reducing hospital readmissions by 20% by the end of 2013, which we're approaching, so it'll be interesting to look at those numbers as we move into next year. For those of you who don't know me that might be on the webinar today, I have extensive background in culture change and person-centered care in the long-term care communities, assisted living, home care specifically, and have spent a great deal of time in the last 12 years really reinventing myself and the approaches that I use in care and operations. So my language and approaches may sound different to you, and in some cases sometimes they sound too warm and fuzzy. And in order to reduce hospitalizations, I do think we can be more warm and fuzzy relative to the people that we take care of and still do great work. I think the work that goes on in particularly healthcare today is sacred work. The people who are closest to the patient in the hospital or to the resident living in the nursing home or receiving rehabilitation, or to those that we're seeing in home health or adult daycare programs, that it's sacred work that the staff is doing, and a sacred relationship that can develop between the person and the caregiver, or what we would talk about as a care partner in the Eden alternative. I also want to make sure that we're on the same page, that when I talk about culture change, I believe it's about a national movement that's gone on over the course of a couple decades to change the culture of aging and transform the way we provide care, specifically in long-term care. But there's a number of organizations like Plaintree that relate to acute care, and there's a lot of organizations across the country that work throughout the continuum of care. People can become institutionalized no matter where they're receiving health care or even when they're living at home. When we talk about person-centered care, we're talking about honoring the choice of the individual, the person, the resident, the elder, the patient, their routines and schedules, interests and activities, autonomy, and self-determination. And so many times in a short stay, whether it's at the acute care hospital or in the skilled facility or in the home health agency, it can be difficult to figure out what these are because we're with the person for such a limited amount of time. But one of the things in the culture change movement that we have focused on in trying to deliver person-centered care are the domains of well-being. And although I don't have a slide about this, I do want to talk with you briefly about these. So there are some domains of well-being that no matter where we touch the person on the continuum still remain important to them. And they are identity, growth, connectedness, autonomy and choice, security and privacy, meaning, and joy. I'll say them one more time because they're not on a slide. Identity, growth, connectedness, autonomy and choice, security and privacy, meaning and joy. All of those can become a part and remain a part of a person's life regardless of where they are touched on the healthcare continuum. And I think that we could focus more on those. And in some cases, maybe that would have a potential to impact the reduction of rehospitalizations. On the next slide, which would be your fourth slide, I've placed there for you, which you can find on the CMS website, basic understanding of how to identify rehospitalization rates. So unplanned hospital rate is what CMS calls it on their website. And they do differentiate about inpatient status, someone who's on inpatient status versus in the emergency room or under observation, and a planned admission that should not be counted because someone has elected to have surgery or something else going on. And then it's also adjusted for census. So I would spend some more time. Many times then we talk about those rates in relationship to patient days or resident days in terms of 1,000 resident days. So look at these rates. I know where I was working recently, the health information manager managed this particular rate for us. And actually we did use the Interact worksheet that's been attached today for the webinar to help you with that. So just sitting there for basic information. I have to believe that probably most of us know about this, but if you don't, this is a good starting place to even go back and establish maybe over the course of the third quarter of 2013 what your hospital readmission rates look like. And Natalie's already shared with you the information on the next slide, but these are goals for the Healthy Transitions partners for the campaign, wanting to save $80 million in healthcare costs, preventing 8,700 hospital readmissions to keep people out of the hospital for a cumulative 34,000 patient days. And there's also goals to improve care and reduce costs. We do know, I know from my long-term care experience, how disruptive it can be for an elderly person to go to the hospital. They can become very disoriented, develop delirium, and puts them in a very vulnerable position for other issues and comorbidities. So we want to make sure that we're really focused on reducing these rates. We can accomplish these goals, but in addition to that, we'll accomplish improving care. A current understanding on reducing rates, just in review of the literature and review of what's going on in the state, and what I know is going on in long-term care, and you may or may not be able to validate this in your own organization, that we know that a lot of long-term care communities are measuring rehospitalization rates, and that the hospital is doing the same. and that in the future we're looking at a different way for reimbursement and bundling services. We've also seen a reduction in rehospitalization across the continuum. So we've seen some improvement. Hospitals are using research from Project RED to change discharge planning processes and have been doing that for some time. Rates have dropped in larger urban areas but still remain high in rural areas of Colorado. And Dr. Coleman actually recently addressed this and said that some of it is related to on-site availability of a primary care clinician. It could be physician, could be nurse practitioner, might even be a registered nurse. The inability to obtain timely laboratory tests and intravenous fluids. I think in long-term care we know that, especially with staffing waivers that we might have in place. Problems with quality of care in assessing acute changes and unstable condition at the time of discharge. I also know I talked to one of the partners today who had looked over the PowerPoint for the webinar and hoped I would talk about adult daycare. We know that nationwide we've seen a 38% reduction in rehospitalization for those elders who are seen in adult daycare post rehabilitation or SNF location. And they've seen that consistently at 30, 60, 90, and 120 days. Randy, I appreciate that information for the webinar. Eric Coleman recently said that there's really no one in charge about rehospitalizations, and that's probably one of the reasons that we have so many issues going on, that no one's really wrapped their arms around this and been identified or held accountable in a particular healthcare setting. He said, furthermore, not one healthcare plan, but many, I know that from my own experience dealing with every particular managed care organization, insurance company that was interested in finding a way to receive skilled care for people. Nobody asked the patient about their goals for their care. It's all about what the health care plan might suggest is the goal, the physician might think is the goal, or the provider of therapy services might think is the goal. Healthcare providers aren't working. I think we're getting better, but haven't been working at a single list of medications. So what is the reconciled list of medications that's current for this particular patient? They don't understand or attempt to overcome patients' limits on self-care. And many times, I know we saw that in long-term care after rehabilitation, trying, to look at the metrics, the benchmarks that managed care organizations might have, and when someone should be discharged, and an outlier, particular elder, was just not meeting or fitting into those, and then taking the risk of discharging them too early certainly then could present themselves back at the hospital. Improving care and reducing hospital readmissions requires addressing the problem, Dr. Coleman said, and fundamental to that is improving patient engagement at every stage. I think this was really telling for me. I think patient engagement is all about person-centered care and culture change. It's about handling the individual, and not handling them, but supporting them and making sure that we know what's important to them. So I'm going to spend some time now talking about that, improving patient engagement. So for those of you who are really, culture change folks out there, and I say patient, I do think when it relates to the person who's receiving acute care hospitalization, they see themselves as a patient. And they're there as a patient to receive care. They're still an individual. And those of you working in long-term care, assisted living, home care, adult daycare, or even for someone living at home, you might be providing concierge or home care services that aren't skilled, that these are still a patient on the continuum of healthcare. I also want to remind all of us that I believe elders have the ability to make decisions. They always have. If they can't tell us, they let us know some other way, even those folks who are living with dementia, and that they have a desire to remain as independent for as long as possible. And there are some people that won't say this to you, but many people will tell you that's how I want to live the rest of my life. Now, that doesn't always mean at home. So the next slide, patient engagement at every stage of care. So I think that this can be relevant no matter if you're in acute care, if you're in the skilled arena, if you're operating in home health, assisted living, maybe a CCRC that has independent, skilled, and assisted living. You might even have home care in that particular situation, adult daycare, or someone living at home or returning to home after a hospital stay. At the time of discharge from the hospital, we want to ask ourselves on some of these things. I think they're pertinent. I think you can ask them at every stage. Where are they going? Where is the person going? What do they know about it? Have we informed them, or are we creating more fear and anxiety for them in not engaging them? Who is going to be the home care agency? Do they know? Have they met that person? Could we take the opportunity to partner with a few rather than multiple home care agencies? I know, working in the skilled nursing facility, that every managed care organization had different, every system had different home care agencies, and it was so hard to manage all that. As our staff could develop relationships with a home care agency, we felt like the outcome to the patient was much better. How much have they participated in the decisions about what happened with acute care, about where they're going, about what their goals and objectives for themselves is? In the skilled nursing facility, who's going to be their roommate? How long will they be there? I don't know if hospitals realize that when you go to a skilled nursing facility, today a person going there may be faced with a semi-private room or a shared room, or they may have the opportunity for a private room. But if they have a roommate, did we pick the roommate right? And can we figure that out? If they've been there before, can they have the same staff that they had the last time? This would forge a relationship factor and undoubtedly help the person reach their goals quicker. So the skilled nursing facility, that community can really look at, can we put this person back in the neighborhood that they've been in the past, so that they can appreciate having the same staff. And if not in the same neighborhood, can we still assign the same staff? So can they have the same therapist, the same care partner, the certified nursing assistant, the same nurse? There's undoubtedly some trust that's developed there in the relationship, and that will create less anxiety and fear for the person who might be moving. What does the staffing model in that skilled nursing facility look like? Can it meet the needs of those particular patients, and how much is consistent assignments done so that the person moving to that place can have the same staff caring for them over and over and over again during their stay? That's a tenet, an important tenet of person-centered care, one that the state of Colorado on the Medicaid side reimburses for in a small additional payment through the Pay for Performance program. How will their discharge date be determined, and when? Who's going to be involved in that? And how are we sure that the elder themselves can be involved? And what are the needs for aftercare? What do they believe the needs are? What does the professional believe the needs are? How can we do education about that so that they'll really appreciate that? And can they meet the care partners that are going to be working with them, the caregivers, the nurse, the therapist, the CNA in the home health agency or at the assisted living prior to the departure? So that they can, again, be able to forge a new relationship. It would be important for these to be people that they might see in the new place so that they'll remember them. Finding out something important about them. I know that we always thought it was important to find out the story about the person so that we could relate with them on move-in day and be more welcoming about their care when they came to stay with us. What education do they need prior to discharge? I think on the skilled side, I see hospitals having, I had the opportunity recently to do some clinical practice supervision for the registered nurse program at Arapahoe Community College, and I can see in the acute care setting that there are huge education departments and a lot of patient family education that goes on prior to discharge. I think that's an opportunity we have on the skilled nursing side to figure out more of how can we do more education with the patient. I do think there's opportunity in the Medicare program for that to be covered as a skilled service. It does have to be documented. I think reconciliation of the medication list and sharing that with the patient and their family is extremely important. Many times, you know, meds didn't get reconciled before they came to skilled, and then they get there and say, well, this is what I was taking at home. Sometimes the doctor has changed the medication intentionally for a good reason. Sometimes the provider, the physician on the skilled side doesn't want to inject themselves into changing medications that they've been on for a long time, but there really needs to be re-education done about that. And at the skilled nursing place on the continuum, we have to do more and more of that. In medication administration, we need to identify any warning signs that we want them to look at when they get home. Okay. Next slide is about new process. Excuse me, I'm going to take a drink of water here so I don't have that coarse throat. New processes that are needed. I can't tell you how important I think consistent assignments is to the outcome for the person. They're likely to achieve their goals faster and have consistent intervention while they are receiving services if the same staff is assigned. They're likely to have those domains of well-being that I talked about earlier met when the same staff is working with them over and over again. And this would be included on any kind of readmission that occurs. Developing new move-in and welcoming processes. One of the things that we talk about in person-centered care is about simple pleasures. What is that elder's simple pleasure? What really is important to them on a daily basis? These are small things, not costly things. Doesn't mean you have to have their pet come and visit, but these can be things that, you know, they have a routine, and if they want to stick to that, sometimes when they're not feeling well, they want to change that routine, and we need to inquire about what these simple pleasures are and see if we can provide some of them. Sometimes they can be something as simple as that first cup of coffee or that special kind of tea, or something that they like to do every day that can be provided every single opportunity that we have and may be part of that new welcoming process. New approaches to patient education and discharge planning. I already spoke about how important these are, but a comprehensive and acute medication list with medications provided at the time of discharge. Many times we give them a list, but we send them home without medication. And we need to work on this. We need to work on it with the managed care plan, and we need to work on it with the pharmacy provider because they're not in a place where they can go and get those medications, and then we risk that they're going to take what they already have at home. Patient engagement and education, we need to be individualized about the patient and the approaches that we use in caring for them. We need to do follow-up telephone calls. This is one of the elements of the Project RED and Dr. Coleman's work that acute care facilities have been doing. And I know, having been a patient in the hospital over the course of the last few years myself, that I had follow-up discharge calls. I think they're extremely important. And a starting place for the nursing home who is doing rehab and returning people to the home is to think about who are the riskiest and can I start with phone calls to them. So think big, I want to do this for everybody, but start small, and so where do I start? It would be important for them to have a nurse who's been caring for them while they were with us make that follow-up telephone call to them. Interval communication then, you know, I think the hospital doesn't necessarily think about this because the length of stay is so short, 14.9 days. The length of stay on the skilled nursing side in the country hovers somewhere between 28 and 32 days. Some of you are probably less than that. Some of you are probably more than that for the average. But then that kind of calls for interval telephone follow-up at maybe 2 weeks, 30 days, and even beyond that. And could you have them back? Could they come back? I know it helps our revenue stream, but could they come back for therapy services? I think there's continuity of care offered there. I mean, if they're not going to receive skilled home care, then can they receive Part B therapy services and go back to where those were provided in the SNF and see the same therapist? The likelihood for us to see a change and be able to help them with that change. And remember, on the skilled side, if someone's left the skilled nursing facility within 30 days and has a change of condition or is now eligible for skilled services again, they don't need to go to the hospital to come back. They've already met that requirement for a 72-hour stay in the hospital. They can be a direct they can directly move into the nursing home and receive skilled services again within 30 days of discharge. Comprehensive follow-up and accessibility for the home care agency staff is vitally important, making sure that we're communicating effectively with them. Sometimes I would hear regularly from home care agencies, I didn't get the right paperwork, or, you know, I can't initiate care because I don't have orders. And we have to get better and better at making sure that they have that. We're all partners along the continuum and have to work together. And then we need stronger advocacy for the patient when they're discharged. When the discharge plan is risky. So sometimes the managed care organization is pushing us. They think the person's ready for discharge. And we have to push back when we think it's risky for the sake of the person and help them get those services that they are continuing to need. We have to coordinate then with managed care organizations. We could use things like smart technology to help us in understanding this person better. There's, you know, one of the things, I don't know if hospitals and everyone else knows this, that long-term care is really working hard on reducing the use and eliminating the use of alarms, just like we did side rails and physical restraints. And a noise factor can significantly change the person's ability that already has sensory loss in their ability to participate in their plan of care. So we could use things like smart technology that will tell us how someone's moving around the room or how frequently they are, and intervene before there's some kind of fall or other outcome that occurs. We want to rely on customer satisfaction as a guide to improving outcomes. So let's look at those. Let's make sure we understand them. Some of that occurs by feedback that one of us gets across the continuum from a particular patient and how we communicate about that. Okay. The next slide I put in here, I thought this might be new information for many of you. I don't know, what the variety of participants, where you come from today and what place on the continuum of care. But on the long-term care side, one of the things that we've recognized in, I believe it was a Rothschild grant that the Pioneer Network and I believe the University of Wisconsin nursing program had a few years ago, was to identify the competencies for nurses that we needed to develop in order for culture change and person-centered care to really take hold. That in some cases, the nurse might have been the last to really get on board, and sometimes it was because they hadn't had the education and training, they didn't understand the competencies, they were concerned about their risk and liability in relationship to the standard of practice and their Nurse Practice Act in their particular state. So there are 10 core competencies here that we believed as they finished this study were really necessary for us to help the nurse gain, particularly the registered nurse, in trying to take better care of the folks that are coming to the skilled facility and ultimately be able to help them with a good discharge to home or to the home care agency. And what does that really look like? So if you look at items 9 and 10, you can particularly see that problem-solved complex medical psychosocial situations related to resident choice and risk. So sometimes an elder's telling us, oh, gee, I want to do this, and we understand there's this huge risk. Modified texture diets could be an example of not wanting to follow those, or the use of thickened liquids. And being able for the nurse to help the person understand the risk versus benefit, and making an educated decision. And then facilitates team members, including residents and families, in shared problem-solving, decision-making, and planning. Making sure, I think so many times we have families, really trying to follow up and understand what the next steps are, and they may not be the same perspective as the elder or the patient, and we want to make sure that we involve them. You can certainly look at these others, but I think those two are really relevant to what happens with rehospitalizations. And then that brings us, so for many of you I know have already looked at these Interact tools, and I understand from getting ready for this webinar that the Interact tools are coming for assisted living. I do think that there's probably a little different approach in assisted living. You know, in the hospital, we have a really heavy registered nurse, and of course, in order to get magnet status, we're seeing more and more registered nurses employed rather than LPNs in the acute care arena. And we're seeing, excuse me, we're seeing that in skilled nursing and rehabilitation as well. But there is some assessment that needs to go on in order for us to prevent rehospitalization. And so I did pull, there's a lot of tools available on Interact. All you have to do is Google Interact, and if in the top of the bar across the top of their webpage, if you just go to tools, you'll find all of these. And there's instructions for all of them. There's more tools than I pulled for the webinar today. But there's an acute care transfer early warning tool. There's a stop and watch, an SBAR communication tool, and a medication reconciliation worksheet for post-acute care. I have had the experience of using all of these, and I think that they can be really effective tools. So if we can take, I know some of, I hope you can see these, but if you can't, if you would go and look at them when the webinar is finished, and on the skilled side, if you're not using them, this may be an opportunity for you to start thinking about them. One of the first things that you could do is find a way to complete the acute care transfer log, because it'll give you some signs. It could be used for your quality assurance performance improvement. It could be a way to look at data that helps you identify where you might be having problems. But anyway, the acute care transfer log makes you log in all of those transfers to the acute care facility so that you can see them. You can see what time of the day they occurred, from what neighborhood or unit they occurred on, what the reason for the transfer is. So right away they'll show you, gee, I had 5 of these people going out for pneumonia. Or I had 6 people going out and ended up having UTI. So you can see right away what your problems are, why they're going out to the hospital, and then you can begin to react to, what can I do to prevent this from happening in the future. You could also see what neighborhood or unit they're occurring on and then be able to focus on that. So again, if you were going to try to develop an action plan for quality improvement here, you could start in a small way and eventually get through your whole community. I found these forms really helpful. We use them in morning meeting every day to look at what our trends might be across a few days or a week at a time. This is in a place where we could easily have discharged 10 folks and admitted 10 folks and sent 3 or 4 to the hospital in a 24-hour period. So that's one of the forms that you might think about initially using. The other form that's a lot of fun is the stop and watch. I know it's hard for you to believe that. I think it would be fun. But this is a form that you would give to the care partner, to the CNA, who would fill it out and communicate with the nurse about what they see that's different with this particular patient or elder. And if this happens on a regular basis, then we might have, a window of opportunity. Maybe we have 72 hours or more that we can actually begin to clinically assess, communicate with the physician, and understand what's going on with the particular person, and then put interventions, physician's orders, actions in place so that we don't have to send them out to the hospital. So this is an early warning tool, and it can really be fun to use, and I think it really involves the CNA who would love to figure out how they can be more a part of the process. And many times they see these signs. And then if you're doing huddles, you could review this at the huddle every day, a way to communicate through the nursing team about what kinds of changes we're seeing and then how do we intervene. And then the SBAR, which is probably the most common form that Interact has, is really going back and doing an assessment prior to communicating with the physician about what's going on with the person, so that you have all of the information in front of you when you make that call to the physician. When you don't have it, the physician feels at risk, just like we do, and because he doesn't have enough information, feels like a physician or clinician needs to lay eyes, another provider, on the person and sends them out to the emergency room. We want to avoid that, and so we'd want to complete the SBAR prior to calling the physician, finding out what else he needs, and then encouraging, if you can care for this person, could we start IVs? Could we start oral antibiotics? What are some of the things that we could do so that we could prevent that rehospitalization? And then the next form is a medication reconciliation worksheet. I can honestly tell you that in my experience, we developed our own. If you have an ability to be electronic about this, I always think that handwritten can give you some opportunity for someone not to read it correctly, especially if we have people that we're trying to educate about their new meds or changes in medications that have visual acuity issues. We want to develop a reconciliation, and you can see from this form the medication says medications recommended by the hospital at discharge for which clarification is needed. And what is that clarification, and what's the resolution for the order? So, you know, maybe we've changed the Lasix, or, you know, maybe we've changed, undoubtedly we have changed the Coumadin. But, you know, what are those changes, and what are we supposed to do now? And then the second part of the form is what were the medications taken before hospitalization, not currently on the hospital's list, and what's going to happen with those. So patients need this information in order to effectively manage their medical comorbidities once they return home. It will help the home health nurse if they're going to a home health agency, and it will help the family if there's a family caregiver or an outside caregiver. In the case of an adult daycare, if they're administering any kind of medications, it might help them as well. So we actually developed our own form, and it was typed. Actually, we did it electronically, and we're able to save that document in the record, and that was really helpful for us, you know, to look at retrospectively and trying to do root cause analysis and those kinds of things. There's also care paths on the Interact website that you can look at that should give you some, you know, understanding of how to use some of these documents a little bit better. That's only a few of the things that are on Interact. There's other programs out there. I know there's COMS and other things that can, other systems that can be used to effectively evaluate before hospitalization. I want to have a caveat that, of course, if someone is has an emergency going on, transfer to the hospital is always appropriate. But there are many times that we could avoid hospitalization by doing a thorough assessment and appropriate communication with the provider so that we can get that person what they need. Undoubtedly, their opportunity for recovery is going to be better and faster before we return them to the hospital. And remember, in the beginning, we started with talking about how disruptive hospitalization can be to the elder. My last slide just kind of gives a little person-centered alignment with rehospitalizations and the quality assurance performance improvement. Acute care facilities may not know that, you know, in long-term care we're required by regulation to do quality assurance, and we have some changes coming down the pike, which includes us to be more community-wide in our focus on this, community-wide being the facility, and doing things like root cause analysis and documenting that root cause analysis, but that's going to get us much more person-centered. If we have, you know, issues of choice and individualizing care and those kinds of things, this QAPI approach can help that. It's going to require us to move decisions much closer to the patient than we've had them in the past, and hopefully putting the person before the task, which has always been a goal of person-centered care. So that's all I have today. Do we have any questions? David's working on questions, so just hang in there a minute.
If you have questions, I am unmuting. Hang on just a moment. You can hear all sorts of chatter there in the background, so if you have questions, please ask Beth. Everybody should be unmuted at this point.
I hear you. Any questions? Any friends out there that want to speak up? Who's that laughing?
They wish to remain anonymous.
I guess so. If there's no questions, I just want to, I didn't put a slide together that had my contact information. If you would like to email me or call me, I'll be glad to do that. It sounds like some of you are on your email, but my email address is beth, beth.ertz, I-R-T-Z, at focus-consultation.com. And my cell phone number, if you'd like to reach me, is 303-495-4805. It's been a pleasure to do the webinar for you today. Thank you so much.
I think we have a question.
Okay, so we have a question.
What work is being done in assisted living facilities?
Well, that's a really good question. It sounds like sometime in 2014 that Interact is developing approaches or tools to be used that, like we talked about today. You know, one of the things that I thought about in developing the webinar today was the ability to have some kind of resource, some partnership. Some assisted livings are in a continuing care retirement community, and so there's undoubtedly a nurse available to them to make some kind of evaluation and assessment of a person prior to sending them to the hospital. Many times there's also a physician, but in other cases they may not be on site. So I do think that's something that, you know, we really need to work on, because undoubtedly then the choice is to transport them to the hospital, to call the family and ask them to take them or to call 911. In some cases, there may be the ability to have a nurse do some evaluation and then communicate with the physician. And if they've been, if the person has been discharged from a skilled nursing facility in the last 30 days, contacting the skilled nursing facility, reviewing what's going on, and asking for direct admission and coordinating with the physician may be an opportunity.
Provide your email address one more time.
Yes, my email address is beth, beth.ertz, I-R-T-Z, at focus, F-O-C-U-S, dash, consultation.com. And if that doesn't, if you didn't get that, Healthy Transitions or Colorado Healthcare can provide it to you. I'm happy to be contacted if I can be of any support.
And there was another question about obtaining copies of the presentation. If you would like a copy of this handout, call Donna Hepworth at 303-861-8228, and she will be happy to provide that to you. This session has been recorded and will also be available on the CHCA website. Let's see if there's any additional questions. Let's see. Is there CME available for this lecture? I don't think so.
I don't think so.
And Beth, please say your email address one more time.
It's beth.ertz, I-R-T-Z, at focus, F-O-C-U-S, dash, that's a little dash on the keyboard, consultation, CONSULTATION.com.
All right, that ends this program. We appreciate you participating today. We thank Beth and Natalie for putting this program together. There will be another program in December, so stand by for that information. If you have any additional questions as a result of this webinar today, feel free to email Beth or contact the Colorado Healthcare Association and Center for Assisted Living. Thank you for participating in today's webinar. Be safe, be prepared, and communicate. Thank you.